So I wish we could time the cheers next door to the appropriate time on the slide, but we're going to pick it up again, and Brendon Hale, who is the new Vice President at Penumbra for Health and Market Outcomes Research.
Alrighty. Good morning, everybody. First, I really have to thank Bob for all the great work he's been doing over the years with the IVRHA and all of his advocacy efforts to promote virtual reality in healthcare. I'm here a little bit to challenge all of us to be a little bit more proactive in our approaches to defining the value proposition for healthcare. Why am I saying that it's up to us as an industry to define the value proposition for healthcare is really paramount, because healthcare doesn't know XR, healthcare knows healthcare. And by way of making that statement, prior to joining Penumbra last Monday, I was previously the digital therapeutics research lead for United Health Group Research and Development. And so I sat in a position where we were actively pursuing how best to introduce digital therapeutics throughout healthcare with both the provider organization of Optum and the payer organization of United Healthcare. And so from the viewpoint that I was at, I was very able to understand how best healthcare is looking at digital therapeutics and what the value proposition is for that. A few of the things that I want to talk to today. I'm going to briefly talk about the volume of clinical evidence that exists for virtual reality in healthcare, talk a little bit about advancing healthcare through virtual reality. I'll talk about what XR looks like across the health continuum, how we realize the value of XR data in healthcare, how we need to think about both the commercial and the clinical evidence. And if you notice, my new title is both health and market research outcomes research. Apologize for that. But it's really understanding both the commercial evidence and the clinical evidence that's going to lead us to being successful. And then I'm going to talk a little bit about how we fully define the value with XR data. So currently, there are over 5,000 published journal articles that are supporting the use of virtual reality in healthcare in various conditions, various settings. There are over 600 plus randomized control trials that have been completed, and there are over 125 meta-analyses that are currently published on using virtual reality in healthcare. That is an overwhelming body of evidence that I think we need to leverage. But that body of evidence alone won't lead us to wide-scale adoption of virtual reality, mixed reality, and augmented reality throughout healthcare. As we think about it, these are the VR therapies that exist today that have clinical evidence behind them. And so we have more than 20 evidence-based virtual reality therapies, everything from neuro rehab to musculoskeletal rehab, to grief therapy, to sensory regulation, cognitive stimulation, social skills training, psychoeducation. There is a long list here. The evidence exists to support the use of virtual reality and mixed reality in healthcare. We also can identify the secondary conditions that VR can support. VR can support stroke, traumatic brain injury, concussion, cystic fibrosis, chronic kidney disease. Really what we're seeing is that virtual reality has the ability to be augmentive to all care, particularly in chronic care. And so we see age-related changes, anxious moods, depressed moods, fatigue, grief, sleep-related changes, loneliness, isolation, pain, discomfort, stress. These are all conditions that we can address with virtual reality worlds. Now, as Amir was saying in his comments to Bob, and one of the things that I would like to iterate is, one of the value propositions here is that we can treat both primary conditions and secondary conditions with the same technology. We don't need to have secondary devices. We don't need to have tertiary devices to treat these conditions. We can treat all of these conditions with a single device. And so it really is a fantastic technology. However, we really need to be proactive in how we define the value proposition. So I'm going to change tact a little bit here and talk about how are we going to generate value across the health continuum. And so what we look at when we're talking about health is that health is actually a continuum, and health exists on many planes, and it essentially exists from what you would call optimal health on the left in green, all the way over to disease and disability in red. Now, one of the things that we realize is that throughout our lifetime, or throughout our lifespan, we range from optimal health to suboptimal health to subclinical conditions to all the way up to disease and disability, diagnosed disease and disability. As we think about this continuum, what we see is that healthcare really doesn't address people. Healthcare today doesn't address people as part of a continuum. Healthcare today has largely focused on the right side of this continuum. It's largely focused on disease and disability, and that is very much looking at treatment and management. If we change how we think and how we start to generate evidence across healthcare as a continuum, we can really look at actions like optimization, prevention, and then treatment or management. Now we have platform capabilities and we have ecosystem capabilities that will enable us to actually fully address health as a continuum within virtual reality. Now, if we are able to do that, what we're able to do is we're able to achieve these active states of interest for us in healthcare, which is monitoring people, identifying meaningful changes in their health status, intervening where appropriate, and that intervention is critical to understand where the person is at on the health continuum, so we understand what the level of intervention is needed to actually take place. Not everybody needs the highest level of therapy possible. There are earlier therapies that can be delivered, and so we're quite interested in that, in being able to deliver that. So if we can monitor, identify, intervene, treat as necessary, and then titrate that therapy as necessary, we will achieve kind of the full value of VR or XR in healthcare. And so as we think about that, we really have to think about achieving these actions and aligning these actions across the healthcare continuum. And so I ask the question, how can we enrich the definition of evidence? And that's probably a little bit of a teaser for how we think, or how I think, and how we are trying to pursue the development of evidence to support XR's use in healthcare. One of the things that we realize is that XR generates very unique data streams. And with those data streams, we can associate those unique data streams with specific outcomes or specific states of an individual's health. So as we start to realize the value of XR data in healthcare, we know that user centricity creates valuable data. That data comes in the nature of observable data, which is information about an individual that XR technologies can both observe and replicate. We can talk about observed data, and that's information that the individual provides or generates that can be observed but not necessarily replicated. We can talk about computed data, which is new information that the XR technologies infer by manipulating the observable and the observed data. And we talk about the associated data, and that's information that on its own does not provide descriptive details about an individual. And so ideally what we see is on the right here is that a user provides data when they interact with the XR technologies. That acts as an input. We can have algorithmic control or algorithmic delivery of content. We then have the application or the direct application of the therapy or the action that we want them to take. We can algorithmically control that application or therapy. We can manipulate it or change it, and then we'll see output that comes back to that user. And so what we're really looking at here is a closed loop system that allows us to have inputs, have outputs that interact around that user. Now, ideally what we're able to do when we see this closed loop system is we're able to take that information and relay that information not just back to the user, we can relay that information back to the provider. We can relate it back to the caregiver or their support network. We can also relay that back to the system, the healthcare system. And we can relay it back to ourselves as an industry for learnings and improvements in the delivery of these therapies. And so as we really think about closed loop and these data loops that are generated, we can redefine what commercial and clinical evidence looks like. And so as we change this definition of evidence, what we really want to say is, how can we integrate clinical and commercial evidence to demonstrate value? I will say that what I think is the most important comment on this slide is that all of this data should be used to generate evidence for the actions of monitoring, identifying, intervening, treating, and titrating. But we also have to think about the commercial delivery channels where we're going to market with these products. And so if we're in a commercial approach or a direct-to-consumer approach, the evidence that we want to see is really more around a market adoption approach. We want to see people and how they're interacting with the markets. Do we need to pursue FDA approval for these? The answer is actually no. And pursuing FDA approval or FDA clearance on these will oftentimes result in a misguided effort or misguided pursuits. If we see people with suboptimal health, and think of this as like employer wellness offerings, what we really want to be able to generate is the evidence of return on investment. Are the employers seeing increased productivity? Are they seeing decreased turnover? Are they seeing decreases in absenteeism? Are they seeing, any of their other metrics that they really want to see in terms of performance of their workforce? As we think about subclinical populations, and these are largely a payer or a direct-to-consumer prescription model, we really want to start to look at real-world evidence and how that real-world evidence will support the use of these tools and technologies in healthcare. Lastly, on the far end and on the disease and disability state, if you are making specific claims about disease states and changes that your intervention are going to result in, then you have to have FDA clearance and you have to pursue that path. However, across health as a spectrum, if we think about health as a spectrum, and we think about healthcare as a spectrum, we can really start to align the evidence based on the go-to-market channel that we're interested in and the one that we're pursuing. So as we really think here, how does this commercial and clinical evidence lead us to a different definition of evidence or a new definition of evidence? What we really want to do is that we want to fully define the value with XR data. And so now I would probably argue that this is the worst slide I've created in my entire lifetime. So I will forewarn everybody of that. But what I wanted to do is show how we can think about the optimal health, the health continuum. I also wanted to think about what's our go-to-market channel, what's the evidence that we need to generate based on that go-to-market. And then we want to layer in that observable data, that observed data, the computed data, and the associated data. And now if you think about this, this is a really powerful model of incorporating data types and evidence that we can use to define the value in healthcare. And when we do that, we can be able to go to healthcare and we can say, with this evidence, we are very able to successfully monitor somebody's health. We're able to successfully identify meaningful changes in their health. We're able to intervene earlier. Healthcare is critically concerned with early intervention in healthcare. The earlier you intervene, the lower the costs are for treating that individual. We can talk about the therapies, and when we move over to the disease and the subclinical and the disease and disability, we can very clearly show the value of that treatment, but we can show a much richer form of evidence and show something different than just a dose-response relationship. And at risk of offending healthcare colleagues, most of the evidence base that we use to approve therapies today is largely based on an understanding of a dose-response relationship. And if we treat with X, we see this Y reduction in symptoms. We really can show a much more robust and say a person who engages in this therapy for X amount of time, they show not only improvements in this, but they show improvements in cognitive function, they show improvements in error scores in movement. There's all kinds of ways we can really enrich that data to achieve those 5 outcomes. And so what we truly know is that XR is changing healthcare. However, we must proactively define the full spectrum of value for healthcare. We know that XR can address multiple conditions, which can redefine care models. We can move, and I think Bob said this well earlier, during COVID, care models have shifted. Care models have changed. With our capabilities, we can really now redefine care models such that we can deliver therapies to the person at the time they need it, when they need it, where they're at. And so we can become much more specific. We can use XR clinical and commercial data to define health and health outcomes differently. We don't merely have to identify symptom reduction as the sole healthcare outcome anymore. We can have richer definitions of that. We know that XR can easily be personalized and optimized for an individual's health and their experience. Fantastic capabilities. What we know is that healthcare currently with a brick and mortar model says when you're in my office, this is what I observe, therefore that this is you throughout the rest of the year or the intervening time when I don't see you. We can actually define it differently today. We know that XR can provide on-demand access and availability both in the clinic and at home. We know that XR can ensure that data is seamlessly synced across all of somebody's conditions across the health continuum. And we know that we can evaluate how their health changes as they interact with experiences in the virtual world. Being able to sync this evidence will really allow us to more fully define the value proposition for XR in health. So as we think about, if we integrate data from commercial XR and sensor technologies, this will lead to a more complete representation of an individual. Having a more complete representation of an individual will lead us to better understanding their health and lead us to better outcomes in healthcare. It is imperative that we as an organization and we as an industry, that the XR experts proactively define the relationship between the unique XR variables, the observed, the computed, the associated variables, and we identify those associations with both clinical and real-world evidence that align with that individual's associated health status and their health outcomes. So with that, I thank you all for attending, and I will ask you for questions. Perfect. Oh. All right.
So I'm a healthcare guy. I'm not a technology guy, and so.
Welcome, my friend.
Yeah, here. I felt good about that. So what we know is the system doesn't want to pay for things without evidence.
Right.
And the earlier you intervene, the more impossible it is to get that evidence and to define those trials in a meaningful way to the payers. Right. So how do you see us working with payers? How do you see the industry interfacing with payers? Other than generating a boatload of evidence, how do you see what types of evidence, what areas, where can we make an impact, and how much are the payers going to resist or work with us on this?
I'll start with the last question first and work backwards. So the payers realize that digital is here to stay, and they realize that they need to address the use of these technologies in healthcare, but they need assistance in formulating the strategy and understanding what the evidence base needs to look like. And internally, I can tell you from my previous role, internally there were many discussions about understanding it's fabulous that these technologies exist, but what does all of this data mean? And they don't, because of the training and because of the system, it exists in such a way that there's an understanding of what the evidence base should look like. But what they don't understand is all of the additional data streams that could tell you about the efficacy of the therapy or the effectiveness of the therapy that haven't been identified or defined for them. And one of the very interesting conversations that I can relate to is having a conversation with a provider and with a payer in the room, and them asking the question of, well, yeah, but what does this data tell me? And it's like, well, I can learn things like what time of day did the person interact with the technology. I can do other things where I can use natural language processing if I have voice capabilities, and I can actually understand what's the anxiety or what's the stress that they're demonstrating in their voice while they're going through this therapeutic interaction. Today, you can't, you try to do that as a provider, but you don't necessarily achieve that outcome with the same quality of data that you would otherwise. And so I think it's really proactively defining and aligning the variables or the data streams and putting context around them to demonstrate that for the payers. Good morning, Walter.
Hi, Brendon. Fantastic to see you and to see the fantastic analysis. I guess my question involves something outside of the direct physiological, behavioral, experiential aspect of VR as a therapeutic or as an assessment. And it's more to, we also need to collect the business ergonomics. As we provide an intervention to someone into the healthcare system, it's going to also require adaptation of the healthcare system. Who's going to charge the batteries? Who's going to keep track of the data? Who's going to integrate the data into the EMR? There's a whole batch of ripple effects.
Yes.
Even the more powerful the technology is that we bring in, and the more effects it has, the more ripple effects we'll have through the economics of healthcare. How do we index that? Any thoughts about where can we get that type of data?
Wow, that's that's probably a multi-billion-dollar question. So acknowledging that, and thanks for that. What I think is the challenge, and it's the challenge that I've had in doing the VR work with healthcare providers. It's helping them understand the logistics of device management. It's helping them understand the logistics of cleaning the devices and managing the cleanliness of the devices, if you will. And to that extent, Amir has done great work in that space and doing, the development of specific devices for healthcare. That takes some of the burden off that relieves some of the pressure, but there's more education that we need to do with the providers, and there's more logistics development and logistics deployment that we need to do on our side to better enable them to be comfortable with that. Change is difficult for all of us, myself included. And so redefining that care model is critically important for them, but then also showing them how this will eventually enable them to deliver better therapy. And to Bob's point earlier about the quadruple aim, XR technology really can achieve that quadruple aim, and it can improve the provider experience, but we need to demonstrate that for them. And that's the resistance that I've seen with the early adopter providers are all in and they love it. They absolutely love it, but they're the early adopters, and now we know we have to get the malleable middle group of providers that will adopt it, and we need to solve the logistics problems for them.
Yeah, great talk. Thank you. My name is Xander. So my question is on the integration of health and wellness as like an upstream capture of data for preventative medicine, and how you see consumer devices being integrated with the downstream effects that are often not necessarily available transparently as a form of data stream to the providers. Do you see that? How do you see that evolving?
I've got a quick 1-minute response. I see that evolving such that with the development of platforms and ecosystems that enable third-party content and enable third-party devices to integrate, that we can then track that across time. Now, we are obviously concerned about data privacy, and we want to enable data security for the end users. So that's where we start thinking about what does the individual's health record look like, and what individual data streams are they comfortable sharing with their providers. I think if we saw, I think it was the NHS presentation yesterday, there's a large percentage of people that are comfortable sharing their data with providers, obviously less so with Google and others, or Facebook, right? Or Meta.
Great answer. Thank you.
Yeah. I tried to go through the whole presentation without saying that word.